We are live.
Hello everyone, thanks for joining us. Bonsoir tout le monde. I'm Aurélien Broussal-Derval from KINVENT, CMO from KINVENT, but former strength and conditioning coach. Well, I say former, still very active with some national French fighters in judo. I've got also some professional golfers as well. And I'm with Jante Wagemans, researcher at Antwerp, PhD aspirant, also at the same university, sport physiotherapist. Long story made short, is the physiotherapist of Antwerp Giants. And I'm glad to share this webinar with you, Jante.
Well, thank you very much for the kind words, Aurélien. Bonjour tout le monde. Thank you for having me. So we had that French part. Let's resume in English.
Yeah, because I saw just Rémi Louis and Sophie saying hello tonight. So I know we got at least two French people in the attendee list. So I'm glad to speak English a little bit. That reminds me of my time in Great Britain, where I was strength and conditioning coach for British judo, and where I shared a lot of time talking about ankle sprain, which is, as for every other sport, one of the major injury. That is an extremely common injury. That is our topic for tonight. We deplore in France, excuse my French, but that's the numbers I've got. Obviously, 6,000 cases per day. It's about 12% of sport accidents. Mil cases, the cessation of activities of short duration from 0 to 6 weeks, depending on the gravity. Well, this incident is often trivialized or minimized, and the treatment sometimes literally neglected. Constraints of the match schedule require an early resumption. This may be the reason why the rate of recurrences is very high, 10 to 30% in France. I don't know if you've got the same numbers, Jente, but that is very specific to that injury, isn't it?
Yeah, it certainly is. But let's start with the part. It's a simple ankle sprain. A lot of people think that. Well, no. Let's actually start with the ankle sprain. We use it as a diagnosis. But it isn't a diagnosis. It's more a description of the injury itself. We know we have different categories of how you can sprain your ankle, how you can strain it, how you can twist it. And the lateral ankle sprain is a description of an injury mechanism. It's not a diagnosis. I never heard anyone say, well, I had an ACL sprain or I had a shoulder sprain. No, we give it a diagnosis that the ligament is torn.
Yeah.
So we should first, as clinicians, look at, okay, what's the injury mechanism? And that's how you can describe it. But if you want to give a proper diagnosis, you look at the ligaments. You look at, okay, I have a lateral ligament injury, and then you can say it's a grade 1 with a strain, or it's torn, or it's partially torn. And that's a proper diagnosis. And that's where it starts, because you have to know how the ligament and all the other tissues around the ankle, what the status is. Saying to a patient or from a physician to a therapist, it's an ankle sprain, then you don't know anything. It can be a medial ankle sprain, it can be a lateral ankle sprain, it can even be a sprain at the Chopard line, it can be a syndesmosis, let's say. It can be so many things, but an ankle sprain is not a diagnosis, and that's where it starts actually. And
yeah. What we need to keep in mind that is, ankle is responsible for an essential functional role, and very very basic actually. It's a hinge zone where the vertical stress are transformed into horizontal constraints. And that can impact in many ways, according to the entry point on the ground, the ankle.
Yeah, certainly. And well, you mentioned correctly from the vertical to the horizontal part, but actually it's even more than that. It's multi-directional.
It is indeed.
If we look at the most mechanisms of the injury, it's mostly after a landing from a jump or from a change of direction, where we have the open kinetic chain part. And from biomechanical studies, we have seen it's case control studies and case studies, but nevertheless, they are very informative and very important to make conclusions in further research. You see that the peroneal reaction time, it's delayed, and you can see that it's in multi-directional. So it goes in the supination, it goes in the inversion, it also goes in the plantar flexion, because it happens just prior to the plantar flexion. So it's not just the horizontal part, it's in 3 dimensions, and that's very, very imperative for the rehabilitation itself. So it's not the easy thing from, okay, it's a supination. No, we have to really think in the multi-directional aspect of the injury, because also the ligaments are not just in one plane. The ATFL, the CFL, they're all multiplanar ligaments, and we have to train them like that. But the rehabilitation part, we will talk about it later, but I think it's a major thought in the rehabilitation, how we diagnose this injury, the lateral ligament injury.
Yeah, the exposure is complex, massive, as you said, and meanwhile, this is a fragility zone, very vulnerable zone, and that's such a little region that receives all the weight of the body, and it challenges it in many situations, phases of play, the opposition, specific sporting gestures. They sometimes are very demanding in this matter of rotation and several directions you mentioned.
Yes, indeed, because it's glad you mentioned the different types of sports, because you mentioned the 30% number, and it's actually quite accurate. Because if you look, volleyball has 46% of recurrent injuries mentioned in literature. Rugby or American football, they put it in one category in that specific paper that I looked up. 43%, football 28%, basketball also 30%. So those are high numbers. Those are very high numbers. And also in the general population, we have papers around 40%.
Wow.
And actually, well, so like you already said, people consider it an innocuous injury, so they don't seek medical treatment, or even if they go to the physician, they're not referred to a physiotherapist for rehabilitation. It's considered as something that we can walk off. It will resolve by itself in time. But yeah, if you see the high recurrence rates in sports, and I'm not speaking about professional athletes, those are the recreational, the semi-professional, the professional, it's all type of athletes, of sporty, active people, and yeah, those are high numbers. Those are very high numbers, and it also results in a high socioeconomic burden. So it's not only the injury itself; it's more than that.
Yeah, you gotta. If you guys are listening to us, I think you gotta think about it very, very precisely. If you're exposed to different sports that are classified as more risky than the others, but as you said, even in the general population, we've got numbers, crazy numbers anyway. But if we list the sport that are more risky, we could have, well, first the jumping and landing sports. Yeah, you mentioned basketball, but volleyball, but basketball is huge too. Gymnastics can be of exposure to. Some more street sports as well. We can a bit more modern. The barefoot sports, as surprising as it sounds, where they should have the best proprioception, the less entry points, such as judo or taekwondo, karate, you name it. All those are very exposed to. but after that, you've got all the sports with the direction changes, and contact contact sports such as handball, football, tennis, rugby. That in that matter, the quality of the ground, the state of fatigue, all that plays a role too. For in the end, this is the exposure of this very small part of the body that is exposed to so many constraints. That is to be considered.
Yes, indeed. As we know, in all sports injuries, it's multifactorial. There are a lot of aspects that have an influence, and when Roald Barthes said a long time ago, we can't predict injuries. We can't. We just really can't. There are a lot of influences. What type of intensity? How fatigued? How did he sleep? What? There's so many factors that can influence. But yeah, you said the pitch, the ground. Well, in Aspetar, they did very interesting studies around the type of footwear and the type of the pitch, because they adapted their fields now for the World Cup. They had it in a webinar. I think you can find for free on YouTube, if I'm not mistaken. But it's a very interesting lecture about how they adapted their pitches for the World Cup to avoid injuries. Very interesting. And also, talking about barefoot, I did a research myself a few years ago about how different type of footwear have an influence. Well, not have an influence, but how they perform stability tests. And as you mentioned, the proprioception from barefoot. Well, your thought is correct, because the barefoot athletes perform best on stability tests. So we would think that barefoot population, barefoot sportsmen would have fewer ankle sprains, fewer injury incidents. But yeah, we don't have very conclusive numbers as of yet for to draw any conclusions around this.
Yeah. Maybe we can share with you while you're talking some just a few slides to explain the basic ankle sprain. If you guys want to ask questions, you've got a question and answer, a Q&A pad on the right side of your screen. So do not hesitate to spell it out, so we can take time to discuss it with Jente. Maybe you want to describe a little bit this diagnostic you've got there.
Well, this is the Loga-Hanse classification. This is published a few years ago. Well, actually, a few decades ago already. But it describes how different types of injuries can happen in the ankle and which ligaments are involved. As you can see in the first one, it is the well-known ankle sprain, but there can also be a contaminant injury on the medial side with a fracture. And also then the next one, there is involvement of the syndesmosis, the third one as well, which is more like described as the high ankle sprain, which doesn't exist as well. It's a syndesmosis injury. And the fourth one as well, I think it's an algorithm that every sports clinician most certainly should know. What happens in the ankle? That is the first question that you ask your patient. What happened? And if you see that the patient goes to plantar flexion, supination, then you can see, okay, most of the time it's the ATFL. I think that's the next slide, if I'm not mistaken. Most of the time it's the ATFL. Here you can see with 85%. Then the CFL ligament, 34%. And then we have the anterior side of the syndesmosis, and 20 almost it's a little bit above 25% of the time is involved, and that happens actually when there's dorsiflexion involved, because then the mortise will go out of itself. It gets pushed outside the fibula because of the morphology of the talus, of the talar bone. So that's already a different type of injury. That's not just an ankle sprain. Well, that's not the normal ankle sprain as they say it. That's different injury. That's a different mechanism. So that's very important. Know your mechanism, and from that on, you can go forward in your assessment.
All right, all right. Yeah, very interesting. Lars is asking a very interesting question too, concerning the footwear. Barefoot basketball is not really an option, obviously, but is there a difference between low cut and high shoes in stability?
Well, in our research, but I said, it was a preliminary research. It was quite small. I can send it through everybody who is interested in it. It was cross-sectional, so we can't draw any real conclusions, but it's a basic from where we can go forward. But the low-cut shoes also perform better than high shoes. The high-cut shoes above the malleoli really performed worse. So yeah, it was significant result. It was also clinically relevant result. So yeah, the high shoes really performed worse in
That
this.
is very interesting. I was surprised. I've been volleyball myself as well as a research and development officer, and well, for French national team. And I was amazed to see how many players were still playing since the young age with ankle protection prior to any injury. And so the result is easy. They were just building a glass ankle, very very weak, and after a little while they couldn't remove it at all.
Mm-hmm. Yeah, true. Well, the hypothesis, like I said, we don't have real evidence regarding what I'm going to say now, but the hypothesis is that if you wear braces preventively, you weaken your ankle muscles, because at a certain point, yeah, they don't have to work anymore. Well, but like I said, it's a hypothesis, it's not proven, and yeah, as usual, more research has to be conducted on that part. And to answer,
The only thing we know for sure is that they couldn't take it off. Their confidence is not big enough so they can take it off. So they think, whether or not they can, they think they can't play without.
yeah, and trusting their ankle, the self-confidence is a major part, really a major part.
Yeah, I'll get back to that confidence in a minute because we want to talk about recurrent ankle sprains. But Lars has got one more question for you. It's concerning the footwear. It's sorry, so it's not. We already mentioned that. The result were on stability. Is he asking you, or
Yeah.
do they have less injuries?
No. It was on stability outcomes. So there were different stability tests. The main test was the multiple hop test, which is very easily applicable in clinical practice. Just a little bit tape measure and some tapes, and it's very easily done. But that was the main test, which is proven valid and reliable by a Brussels researcher, Christophe Eekhouten. And yeah, that was the main outcome, and those were the results. Not on less injury, we didn't have that as an outcome.
All right, let's go back to that confidence. Very, very important, since you guys got to be aware that a sequel of a simple sprain can be much more important and embarrassing than intended. So clearly, the athletes may feel pain and apprehension during the activities. pain is one thing, but apprehension is a game changer, isn't it? And because as he keeps playing, he loses confidence in the stability of his ankle. So this subjective criteria causes real functional discomfort and can bring more and more ankle sprain. But it's not the only topic to discuss there, is it?
No, no, far from it. If we can switch to the next slide, we're gonna see. Well, thank you very much. This is a very complex paradigm. This is the newest paradigm in 2019, published by Jay Hurtel and Corbett. It's a very complex paradigm, but in a way, it's very comprehensive as well. It shows all the main factors that are involved in lateral ankle sprains, if we're going to use that term further, and how it may develop to chronic ankle instability. And as we know from one study from Eamon Delahunt, I think was involved, or Kelly Doherty and Chris Bleakley, we have one study performed prospectively, and the numbers showed 40% develop chronic ankle instability. But the main thing is that recurrent ankle sprains are indeed the center of the paradigm. But there is more, there's a lot more. Like you said, you have the perception part, and that's not only the trusting the ankle, also, bless you, but it's also, well, the perception of instability in the foot. So you have to have confidence in your foot, but every time you land and you have the feeling like your ankle is unstable, that's also a big part. And the kinesiophobia, having fear of movement, and of course, even more importantly, the reduced quality of life. We can all say like sports and injuries and landing, but your quality of life, I think, is the main outcome of injuries. And this continues on the paradigm, because this is based on the ROSE guideline published a few years ago, also by the International Ankle Consortium. And they mention what to assess and keep assessing in your patient who incurred a lateral ligament injury. So if we look at what is associated with chronic ankle instability and with the ankle sprains, we look at the dorsiflexion range of motion, the eversion muscle strength, functional performances such as walking, running, landing, but also pain, persistent pain, sensory motor function, stability tests, but also proprioception as a unique outcome can be tested as well in a clinically relevant manner. It doesn't have to be a laboratory test all the time. There are really valid ways to test proprioception, all of these things. And then, of course, quality of life. Quality of life is such an important outcome, and we can assess those with questionnaires. Those are valid, those are reliable, like the Cumberland Ankle Instability Tool, the Foot and Ankle Ability Measure, which has a activity of daily living scale and a sports scale. So there are a lot of possibilities to assess your athlete, to assess your patient, and keep assessing him throughout your rehabilitation. Use comparable signs, comparable measures, so you can reassess and make sure your patient progresses in an objectively way. I think that's very important.
This is a complex enough a joint that you use a proper holistic approach. You can't just try inflection, extension, and say, "Oh, right, that's a safe ankle." It's much more than that, isn't it? We've got a question from Julien. During the IOC Congress last year, studies have shown that ankle braces are probably the best means of primary prevention of ankle sprains without actually taking into account the notion of confidence if they play without. But it does change our view of braces as a result of a problem.
Yeah, the results are true. There was one study, I think, from Janssen et al., performed in the Netherlands, that has shown that using braces supplementary to exercise therapy had very good results in the prevention of a secondary injury. That's very true. But that's only one study, and to have a conclusion, we need many studies who have the same results. We can't draw any specific conclusion from only one study, but it is true that studies shown that bracing helps in the prevention. But there I emphasize the prevention. So after an injury, you give them bracing or taping. Taping also seems to help, but the preference is bracing. And to get them back playing, get them back training, but after a while, try to decrease the amount of bracing that they use, try to elevate their confidence. That's my point of view as a clinician. But indeed, the results of studies show that ankle bracing does help, but it's only one study. But it's a good result, but nevertheless, it has to be.
Yeah. It's interesting because we've been back in the days, we've been promoting it a lot with no real argument, and then we've been asking all the players to remove them, not to wear them whatsoever, because that could weaken the ankle. And now we've got a bit of somewhere in between, thinking maybe there's more to it. We need to consider it. As I said, the main thing for me is the mindset about it, really, which is crucial to me, because if you've got someone that isn't confident with his ankle, that is a big problem. And we've been talking a lot about it, actually, without even noticing it. We've been talking so much about assessing the mindset, yet objectively we observe a decrease in the strength, the reactivity of the vertebral muscles, which protects the joints, actually, and the disturbance of the proprioceptive, for example. So that very concrete things that happens when you injure or you weaken in any manner the ankle. But it always has to be connected to the mindset, isn't it?
Indeed. Here we see the International Ankle Consortium advice for the ROAST guideline, and the ROAST is actually rehab oriented assessments. So with rehab in mind, and let's go further on what you're saying, Aurélien. So you see a lot of ankle joint pain, but in the FADI, it's also a questionnaire, but you see down below, ankle joint specific patient reported outcome measures. This is really important. The FADI, the foot and ankle ability measure, those are really important to know how the patient perceives his own injury. That's so important. I think just published a paper about how patients perceive their injury in lower back pain. Those kind of papers are so important. We should publish more and do more research about how the patients perceive their injury, because that's so important.
Crucial. That is a big point. So, do you have anything to add on assessment, or do you want to move to the rehabilitation process?
I think. Well, we can talk all evening about the rehabilitation, about the assessment process, but I think the main thing is that.
So how do we avoid all this, or how can we help people to get better? Do you have some guidelines for us, and how can we offer the effective means of prevention and rehabilitation?
Well, of course, your patient comes in, you start with your assessment, as we just have discussed. And then a lot of people still do the P-RISE principle. And even a lot of guidelines still mention the P-RISE principle, but a lot of research already has proven that especially the ICE and the anti-inflammatory part is not beneficiary for your rehabilitation. You need the inflammation phase. You need that inflammation. It's the first part of tissue healing.
Isn't it?
So the newest guideline is we need peace and love for our soft tissue, which stands for protect it, elevate it, and avoid the anti-inflammatory then compress it and educate your person on your patient on what's the injury and how we're going to proceed, what's the rehabilitation going to be like, what's your role as a physiotherapist, but more importantly, what's the role of the patient? Because we as a physiotherapists, we don't have the biggest influence on the rehabilitation. The patient has the biggest influence. And there comes the second part, which is optimal loading. We have to load properly. We have to be optimistic about our rehabilitation, vascularize for that first part of rehabilitation, and then exercise.
That is very interesting because it's some people that are listening to us might be very surprised about that. Yeah, it's been out for a while now. Those pieces of advice, but still, I see every day, even in elite performance, many doctors and physiotherapists using massively anti-inflammatories, massively ice. To reduce the inflammation, and that is crucial to keep in mind. That is part of the game. We need to go through that phase, minimum to get the benefit of it.
Mm-hmm. Totally agree. Totally agree. And here we can see exercise, the part of rehabilitation. And yeah, we have to start with rehabilitation as soon as possible. How sooner you start, the lower the chances of recurrent injuries. This is a very interesting study published just a few months ago. And it also shows if you delay your rehabilitation, you have a lot more odds for recurrent injury. And that's a massive paper. That's a very massive guideline that's very important for clinicians, but also information to give our patients. And then
maybe just before we go through that, there is one more question from Bart this time. Well, it's more of a comment, going a little bit deeper into our brace analysis. It precises that about the Jensen study, the brace was compared with an HEP program, not with a physiotherapist guided criteria-based rehabilitation program. So it goes.
He's right, to be honest. Now he says it. I remember it, and thank you for the correction, Bart.
So it goes just a little bit deeper in your observation that we need more data to just conclude to anything in any ways. There is one more question from Julien. The focus on the importance of inflammation is not so much in evidence anymore. We all agree on that. But what to do in case of a fresh sprain, which is actually what you start to develop? Is it really counterproductive to ice the ankle on the field in acute conditions?
Well, that's a discussion, and that can be a discussion for all night if you want. Some say, and some research says that icing can also diminish your proprioception, which can be a disadvantage when you're putting your player back on the field, which can be more susceptible for another injury. And yeah, that would be a catastrophe. But also some other studies have shown results that icing has no effect on proprioception. So there is no really conclusion. There's conflicting results, and to be honest, I don't have a proper answer on this. I wish I had. It's a lovely discussion, which I'm happy to have with every one of you and share arguments and share thoughts. But
I think Julien is quite specific on the timing. I think what he's got in mind is the immediate reaction when the lad gets injured on the field.
Mm-hmm. What to do to put him back on the field? Well, like I said, if you put ice and it diminishes your proprioception, and 5 minutes later you say, okay, coach, he's ready to go back. but he sprains his ankle again, and he has an even worse lateral ankle ligament injury. We really don't know. Literature has no conclusion, and I'm not going to give you a specific answer. I'm not going to give you my thoughts about it, but I'm really happy to have a discussion about it sometimes. But
we can use a bit of common sense there, because it's all about you've got good and bad in every strategy. So there is not one ideal. That's my views as a not as a physiotherapist, because I'm not not as a strength and conditioning coach, but as a player, as a fighter. I got injured badly many often, and when you're in pain, you need options. You don't want to stand on it, you can't, but you can't. Sometimes you need a bit of ice just to cool down properly, at least even maybe mentally, or losing even if it was taking away from me a bit of my proprioception. I don't think well, that's the price I would be happy to pay to release the pain a little bit at the early stage. After that,
well, it's also the question, how much pain does it really resolve? We know that a lot of people used it for swelling, but research has shown that the influence of swelling is not significant. So that's not an argument anymore. So the main thing then, as you point out, Aurélien, does it really help for the pain? If it does, and your priority is, okay, I want to decrease pain so I can play along, it's a really important game. I really have to perform as you are a fighter and you are in the finale. I'm thinking about Alexander Zverev against Rafael Nadal 2 weeks ago. If he was able to perform with icing, I think he would have done it. And I can't disagree, because the stakes are very high. You're in the semifinals of a Grand Slam tournament. You're playing very well against the King of Clay. So in such a match, I would say, yeah, we try icing and let's go for it. But if it's a friendly match, an exhibition tournament, why take the risk? So it's all about a lot of factors. Once again, the decision making is not just pain. It's about a lot of environmental factors once again.
Yeah, and that is where expertise step into the game, and where you need people that are very experimented and are very aware of all the options out there, and taking the good decision at the right time, because you can't rely only on science to tell you what to do. You also need to observe and analyze this exchange with the player that is injured, and take a call.
Indeed, it's on us as clinicians to bring the art of physiotherapy or strength and conditioning together with the science, and innovate in that way to help our patients as best as possible.
Yeah, indeed. Kevin had a question about icing, but I think we answered that. And he's got one more question about how to cleverly avoid ankle problems. So more of a prehab really process, but we'll discuss that later on if you don't mind. So yeah, you can carry on, Jente.
Well, the last part of the peace and love paradigm was exercise, and we see that we have to start rehab as soon as possible. And one of the main thing is, we know that exercise-based therapy works. We performed, I'm happy to mention that I was the main author on this paper, because I'm really proud of it, to be honest, the first paper of my PhD. But it's a team effort, to be honest. I have a whole team surrounding me, and I couldn't have done it without them. So if some of them are listening, thank you very much for your collaboration. Nevertheless, yeah, we have seen, if you look at the diamond underneath, it shows in favor of exercise-based rehabilitation conclusively from multiple articles. So it was an update from a systematic review performed by my mentor and co-supervisor Chris Brickley. He had 7 included articles. We had 14. We can conclusively say exercise-based rehabilitation work. What we don't know is the specific parameters. What's the frequency? What's the volume, amount of sessions, amount of time? How many weeks do we have to follow? We don't have an answer on this. So that's very important for future research and to consider as clinicians. How frequently do we have to see our patients? Do we see them once a week and we give them an exercise-based program, or do we see them a few times a week? Do we see them every day? And that's something we can't conclusively say. And next to that, as you already shown, it's difficult to treat people because a lot of clinicians don't even know how to treat the patients. As you can see from a very important research that is performed, that athletics trainers in the USA are unaware or unsure of the current recommendations about how they have to treat. And how do you expect to give responsibility to the patients in their treatment if the athletic trainers or physiotherapists who have to give the recommendations, who have to give the therapy, who have to inform the patients properly, don't even know the recommendations? And I think it's always a collaboration between the athletic trainer in this instance, or the physiotherapists, and the patient. It's not only the patient, it's not only the physiotherapist or the athletic trainer, it's the collaboration. It's very important.
It's definitely a team sport, isn't it?
Yeah, it is. And there we go to how should we treat our patient? What's the responsibility of the physiotherapist? And that is to implement all aspects of rehabilitation and inform them to our patients. So the main thing is the patient is the center of it all. It all involves our patient. And we adapt everything to that. And it's based on the rehab-oriented assessments that we talked about earlier. So it's objective. We use comparable science, comparable assessments, so we can retest during the rehabilitation. We can look at, okay, what's your evertor muscle strength at week 1? What's it at week 3? What's it at week 5? So, and then we also do stability tests. How do you perform on a side-hop test week 1? Can you perform? Can't you perform? Can you do a drop landing? 2 weeks later, can you do the drop landing? 3 weeks, 4 weeks, 5 weeks. So we have comparable science about progress, and it also gives our patient confidence. He sees the progress himself. He sees, okay, first time I have 50 Newton push on the handheld dynamometer for the evertor. The next time it's 65, it's 85. He sees that he can progress. He sees the progress, and that will give him confidence in his own performance, because at the end of the day, he's the one working, he's the one performing all the exercises, and he can be proud. So that's the second part. Wait, I'm gonna go one back if you don't mind. We also have to consider how to load, because it's in the beginning we load it easily and in a constrained environment, but matches trainings, they're not constrained, they're chaotic. A player comes by, you do a rebound in basketball, there's another player pushing you. It's a chaotic environment. We have to involve this as well.
Yeah, specificity, isn't it?
Indeed. And even, I think, more importantly, and it's something that is not well considered, is the ligament loading. And we all know of mechanotransduction in muscles, in bones, but it seems we don't know it in a ligament. So it is the same principle as a muscle. We have to load it to make it stronger. Only a ligament needs to be loaded in its most vulnerable position, which is in the beginning in low intensity, multiplanar positioning in high volumes, and it increases the tensile function for the viscoelasticity. It addresses the free nerve endings to activate mechanoreceptors in the stretching of the ligament, which enhances your proprioception. And this is very imperative because the ligaments are the only stabilizer of the talar bone. There is not one muscle which inserts on the talar bone, so it's only the ligaments. So if you don't enhance the tensile functions, if you don't enhance proprioception, your passive stability, your mechanical stability won't improve. And at some point, it can be as far as a micro instability, as they say, that it doesn't, the viscoelastic properties are not functional anymore. So that's very important.
And that is something that can occur very, very early in the process, and even before that, answering Kevin's question, as a smart way to prevent or to recover faster when you get injured is to train on a daily basis your proprioception, isn't it?
Well, a lot of studies have shown that training preventively in a neuromuscular way, like stability, sensory motor function, has preventive effects on injuries. Yes, indeed. And then, we have talked about the responsibility of physiotherapists, and that physiotherapists are a little bit to blame because they're not always informed about the current knowledge, the current science. But if you see, this is the PASS paradigm, and it gives a certain guideline to return to sports. But if we look at other systematic reviews, they show that criteria-based return to sports decision-making is non-existent in current literature. And at this point, those paradigms, they're not based on empirical evidence. It's a consensus based, so it can help, but never forget that this is a consensus statement. So you can use it, but don't follow this blindly because it's not based on high quality evidence. And so what I'm trying to say is physios are not fully to blame for the lack of knowledge that is out there. I mentioned that, what was it, 40%, nearly 40% of athletics trainers are not informed about the current guidelines, but a lot of current guidelines are not evidence-based. A lot of times they're consensus-based from experts, and although they are experts, it's still not evidence-based. So we can't fully blame the athletics trainers or the physiotherapists because the proper guidelines for return to sports about chronic ankle instability, it's not out there yet.
Yeah, some other joints, we've got more accurate or more precise protocols, but it's so complex, the ankle, that it's difficult to have proper, very precise guidelines.
Indeed. In the ACL injury, there are guidelines for hamstring injury. There are guidelines for Achilles tendon rupture. There are guidelines, but so forth for the ankle, we still don't have this. And this is the paper that we see, the criteria-based return to sports decision-making following lateral ankle sprain injury. There are currently no published criteria to inform return to sports decisions. And also the paradigm for chronic ankle instability is also it's not based on high quality evidence, and that you can see in the editorial we wrote with again my mentor and co-supervisor Chris Bleakley, which is really he's a very good researcher and a very good mentor. But we published this in the British Journal of Sports Medicine, and there we elucidate a little bit on what we don't know, the gap of knowledge on chronic ankle instability. So we have to beware on how we look at those paradigms. They're clinically relevant and they can be a good guideline, but just don't follow them blindly. Still be pragmatic about it.
Again, guidelines.
Guidelines, indeed, guidelines.
Alexi?
We are at the end of our slides.
All right. So we had one more. Well, that's almost the end of the webinar. Then I've got just two questions for you, Jente. What about the age-related risk exposure? Do you have any data on that? Because many people that are listening to us are maybe exposed to different type of public, especially in sport field. Do you know a different exposure according to age or biological development of players?
Well, we know that the minus 18 population have a high risk of recurrence, and also if they have incurred a lateral ankle ligament injury, they have a high percentage of high odds of developing post-traumatic osteoarthritis. If they have multiple giving away episodes, multiple recurrent injuries, so that's something to be aware of. Also, we have seen in studies that the female gender has a higher risk of recurrent injuries as well.
That was my second question.
I read your mind, Aurélien.
That is very interesting, because going back to the ages before talking about the women, well, the numbers I've got is somewhere in between 15 and 24 in France, about 36% of cases, and it goes down a little bit to 33% of cases from 25 to 34. So it's a little bit more exposure there for the teenager and young adults. Yet the kids are not much exposed, are they?
Well, they increase much more considering their health, again, considering tissue recuperation. It's normal. They're young. They play along, they get injured, and a few hours later, their tissue it resolves much more quickly than we have. How were you, Aurélien, when you were young, playing around, fooling around, and getting injured an hour later?
Yeah, brilliant. Happy times.
Well, you're still young, so
yeah, maybe. And and so the women seem to be more affected than men, especially in the re-injuring process. That's what you were saying a minute ago. What would be the explanation for it? Do you think it's the natural laxity that could be the main reason of that, or? That's
possible, but those are all hypotheses. I think it's a little bit outside of my research expertise to give try to give explanations on that part. I think biologists should try to explain that. But I absolutely
that can just as well be the way they practice as well.
Yeah, they're all
just
again. It's multiple factors because as we have seen, the environment of female sports is not the same as with men, and in a way it's a shame because they deserve equal possibilities to develop their sports, to learn, but as of today it's still not the same, but maybe that can be a factor, but we still don't know.
Well, food for thought. Mate, that was lovely talking to you tonight. That was such an interesting discussion, Jente. Looking forward to the next one. If you guys want to know a bit more about him, he's active on Twitter. You can follow him online. Again, guys, stay tuned because there'll be more KINVENT event in the future like that. Thank you for sharing the time with us tonight. And just before leaving, we've got one more question from Jane Black, getting people to understand that the recovery is more than what A&E has told them is very difficult. Rest eyes, compression, and elevation, for example. I find also that PTs are of the mindset that when pain is gone, they are better. I do test to show them they are not better, but just pain-free, but very hard. Yeah, definitely, Jane.
I agree. Nice thought. Nice way of working.
Yeah, that's a nice way to end this webinar. Thank you all, guys, and I see you again soon.
All right. Thank you for having me over there, Alexis.
Slides.
Ciao.
Yeah, thanks.
Bye-bye.
Just let you know, everyone, you got the slides at your disposal to download if you want in the file section of the right part of the screen, where you could actually get back all the slides we presented to you during this webinar.
Sweet. Bye-bye. Good evening, guys.